Research in Ireland has shown that 1/3 of patients over 65 years of age admitted to a hospital accident and emergency department were on inappropriate medication. So be it through commission or omission, medication error seriously impacts on patient outcomes and the quality of life. And patients need to be facilitated in assessing the benefit and risk aspect of the proposed treatment. It's important to raise awareness among patients that medication is a risk area for them, and they need to be involved in understanding their medication. Why this particular medication, the dosage, the frequency, the impacts, side effects, how compatible with their existing medication regime. And I'm really heartened by the fact that this is now a statutory requirement for pharmacists to engage in consultation with the patient about these specific topics. Patient safety in relation to medication is actually now being underpinned by legislation. And I think that's a good thing, because it's not Big Brother, but it does let everybody know where they stand. And I have found that when people know what is expected of them, they are pretty good at coming up to the bar. And especially when patients move from one care setting to another, say between home and hospital, between long-term care facilities and hospitals, and even within hospitals when they're moved between units, a significant level of discrepancy between actual medication treatment and what was intended can arise. It has been estimated that the degree of error which occurs at these transition points can be as high as 46%. Now that's huge. Like, as a layperson, I find that quite disturbing. Therefore, a process of medication reconciliation is required to ensure patient safety. But when these errors occur, you need to be aware that they have occurred, and you need to have some indication of how to go forward to prevent that kind of recurrence. And I think this particular tool could very well be something that would push that forward. So each time a patient moves from one setting to another, it's important that pharmacists and clinicians compare previous medication orders with any new orders, and that the plan for care, and then reconcile any differences before delivery. It's also estimated that in the hospital setting, there may be as many as 30 to 40 steps in delivering a single dose of medication to a patient, and it stands to reason that each one of those steps has potential for error to occur. And some of the causes, the proximal causes of medication error, have been identified as, for example, lack of knowledge about the drug, lack of information about the patient, violation of rules, slips and memory lapses, errors of transcription, faulty checking of patient identity, faulty interaction with, say, other services, communication, faulty dose checking, drug stocking and delivery problems, and there are, of course, some preparation errors. And I certainly remember, with a family friend, going to see her some years ago, and she was awaiting a transfer to a hospice because her condition was terminal. And the nurse came in and left her medication on the counterpane of the bed and walked out. And to my shame, I did nothing about it. I did make sure that she took the medication, and I did tell her family that this had happened. But, this is an incident of, say, something not being done as it should be done, or taking the easy way out or whatever. So in our efforts then to assure patient safety, examining the relationship between individual responsibility and accountability for erroneous performance, and the need to also look behind the individual to flaws in systems, is a cultural shift that is challenging for all concerned. You can't separate one from the other. It's nice to say things like a no-blame culture, but that is almost tantamount to a child saying, "Mammy, it fell." It happened for a reason, and maybe there was an individual involved in that. And for everybody's safety, including that individual himself or herself, that needs to be looked at. So it is challenging for all concerned, the organisation, the healthcare professionals, the regulatory bodies, the legal system, patients, carers and the media. But we can't shirk our responsibility because the cost of not doing so is too high in terms of quality of life and maybe even preservation of life itself. The community pharmacist, traditionally the community pharmacist and also the hospital pharmacist have been watchdogs in relation to identifying potential medication error and also through querying, for example, illegible, ambiguous and incorrect scripts. The community pharmacist in particular is well positioned to reconcile new medication with the patient's existing regime and can often prevent harm through highlighting possible incompatibilities within the patient's drug cocktail. And it is really good to see that in this particular initiative, pharmacists now have a mechanism to capture that data and share their learning with fellow professionals. So in summary, I think we can agree that safe prescribing, safe dispensing, safe drug administration, safe monitoring, together with safe transition between areas of care, are essential components of any strategy for prevention of medication error. Reporting and learning have to be components of the strategy, and this will facilitate that. And that also indicates that the way forward has to be through partnership, collaboration, which will require that level of openness and transparency, honest acknowledgement when shortfalls occur, resulting in the identification of areas for improvement. And that's what this is all about, identifying areas for improvement to prevent recurrence. And it also requires that reporting of errors, the monitoring, evaluation, testing of systems, processes and behaviours are viewed as positive interventions with which to cooperate, not as policing measures to be resisted. A few short weeks ago, the internationally respected surgeon Atul Gawande asserted that more than anything, what distinguishes the great from the mediocre is not that they fail less, it's that they rescue more. And this is a rescue initiative. Consequently, my exhortation tonight relates to asking that each of you pharmacists will resolve to operate out of that rescue mode, because it is a real possibility in your area of expertise. On the engagement and collaborative aspect of the work, and as external lead of WHO Patients for the Patient Safety Programme, I really want to articulate once again the words of the Patients for Patient Safety London Declaration, which is our grounding statement and our intrinsic identity. In honour of those who've died, those who've been left disabled, or loved ones today, we will strive for excellence so that all people receiving healthcare are as safe as possible, as soon as possible. This is our pledge of partnership, our patient pledge of partnership. It is my continuing. Oh, it's taken on a life of its own. This is our pledge of partnership, our patient pledge of partnership, and it's certainly my continuing pledge of partnership, because we all have to acknowledge that to err is human, but to cover up is unforgivable, and to fail to learn is really inexcusable. Thank you.